All right, so here's our discussion for our group. How's everyone doing?
Good.
Good, good. Okay, so last week we kind of jumped into the method section a little bit, but there was kind of some confusion on what data we were using, if we were using real data sets, kind of just some things we needed to clear up. So reached out to Dr. Pierce, got those cleared up. So we're just going to kind of rehash our method section a little bit, and then we'll jump into our sampling plan discussion. Does that sound good with everyone?
Yes.
Okay. Sorry, I'm very awkward on Zoom. Let's just deal with it. Okay, so kind of a way to organize our thoughts here. We just have this Google Doc, and the first part is just a general overview of the methods. So I'll just kind of read it, and then we can discuss and add in any points that we failed to capture. So our research question is to determine if sickle cell disease increases the risk of heart disease. Our study will focus on African Americans, male and female, over the age of 18, because this population makes up the overwhelming cases of sickle cell disease in the United States. Our independent variable is sickle cell disease, and our dependent variable is the development of heart disease. To collect our data, we will gather records from cardiac catheterization labs from 3 major Boston area hospitals from visits that occurred from 2010 to 2020. These 3 hospitals identified are BMC, Mass General, and Brigham and Women's. Cardiac catheterization is one of the most accurate tests to measure various degrees of heart disease, and thousands of patients undergo this procedure every year in the Boston area. Data recorded will include percentage female, percentage male, mean age of both males and females, number of participants sickle cell disease positive, number of participants sickle cell disease negative, and number of patients with heart disease that's discovered. Data will be analyzed showing the relationship between sickle cell disease and heart disease and our selected population of interest. So that's our general summary. So the first question for the method section, was the design experimental, quasi-experimental, or non-experimental? What specific design was used? So I think this is a non-experimental kind of study. We're going to analyze medical records retrospectively. So that's from that 2010 to 2020 time period. We're going to use 3 different hospitals. We'll get into the reasoning, kind of why we want to do 3 different hospitals. And then we'll obviously filter out the records that don't apply to our population. So if they're under the age of 18, they're not African American, and so forth. Do we have anything to add for that question or things we failed to capture?
No, I believe that's good for that question.
Okay. All right, so we'll move on. The types of comparisons that we're going to use. So we're using the causal comparative model. So basically what that model is it's comparing the independent and the dependent variable. So the presence of sickle cell disease and the development of heart disease, in our case, those are going to define our groups that we compare. And we're not dividing our groups by intention. So we're not, since we can't infect people with sickle cell disease, that's very unethical. This is just how people are sorted. We're not intentionally doing that as the researchers. We're merely gathering the data retrospectively from that 10-year period from those 3 institutions. Another reason that we're deciding to use 3 hospitals instead of just 1 hospital is to increase our sample size. And it's also to decrease the power of individual practices by institution. So every hospital, every cath lab is going to kind of have its own way of doing business. So if we only looked at one hospital, we might get skewed data. So that's why we're kind of using 3 to kind of even out the differences. Does anyone have anything to kind of add or discuss for that one?
No, that kind of covers it all. And also that using 3 hospitals get a better like sample population of the actual area, not just one localized area.
Yeah, so you get let me just add that in here. Better geographical. Okay.
I think it'll also have a better population representation.
Yeah. Does anyone else have anything to add for that one?
No, the second one's pretty straightforward.
Yeah, yeah, I agree. Okay, so we'll move on. If the study involves an intervention, it doesn't involve an intervention. We're just measuring and recording the data of those patients that did go to the cath lab at those institutions within the last 10 years. In our literature review, most of the studies were kind of done retrospectively. There was the study that was done with the mice, and that would be, obviously they were introducing an intervention. They were actually doing the experimental method, but we're not doing that. We're not intervening at all. We're not treating these patients. We're just recording what we find from the cardiac catheterization records, and then looking to analyze the relationship of sickle cell disease and cardiac disease from the records that we analyze.
Mhm.
Does anyone have anything to add for that one that it was failed to capture? Okay, we'll move on. So was the data longitudinal or cross-sectional? Was the timing of data collection appropriate? So the study is cross-sectional and will involve analyzing the records in our population during the years 2010 to 2020 from the 3 different hospitals. It's kind of repeating what was stated earlier. But just from my clinical, I got to go down to the cath lab at MGH and just asking some of the nurses down there, looking at the schedule. They serve about 30 to 40 cases a day. So, 365 days a year across 3 different institutions. I think that's a good size sample. Rough math on that is like 30,000 records. I don't think we're trying to get to a certain number of records that we hit. We have to analyze at least 20,000, or we have to analyze at least 40,000. I think that our sample size will be adequate. We don't need to set a certain quota to get to. I don't know what you guys think about that.
Yeah, I think that's the number of records we analyze will just affect how broad we can make our analysis.
Yeah, that's a good point. So we look at, maybe we do all this and we have to look at, okay, how many of these records, how many of these patients actually showed the presence of sickle cell disease. And that's going to contribute to like how powerful our analysis is actually going to be.
Yeah.
Exactly.
But I think looking at a 10-year span of individual cases will give us plenty of data for this study.
Does anyone disagree with the time period of 2010 to 2020? I just think that if we went too far in the past, a lot of hospitals are transitioning to paper records, to Epic. So we kind of might get messy if we go too far in the past. Most hospitals have Epic now, pretty standardized. So I think doing it, in a recent decade would be beneficial in that regards.
Also
Yeah.
treatment of sickle cell.
Treatment advances.
Yeah, exactly. You want the most like up
And
to
there's
date.
still a lot of research happening right now on it. So I think it's better to keep it as current as possible too.
Okay. Does anyone have anything to add for that point or any disagreements?
So is this assuming that we had an informed consent to start the study before 2010, so we could identify each patient and just kind of keep track of them as they went through the hospital? Or are we just getting data now for that span?
I think it would be that we were getting data now.
Okay,
So
Like, we're
that's
not going to be following those patients that we're getting though.
right.
Yeah.
That's an important point though to bring up.
so like each visit, even if it's one patient, would be counted a different number of time.
Yeah, so if we were doing this study for 2020 through or 2022, though starting now, and then for the next decade, the informed consent process would probably look quite different than if we're gathering it retrospectively. So we're talking about prospectively, like longitudinally, or like retrospective, and just like factoring that into the informed consent process, correct?
Yeah,
Yeah.
So this is just something that we'll have to look into when we get to the informed consent piece.
Yeah, it's something to keep in mind for our next discussion. Not
Would-
next, but future discussion.
Would it make it easier if we did like a ongoing study, like starting now and then 10 years forward, just because the consent may be easier for that? Or because I don't know what the consent really looks like. I haven't really looked at that. I don't know if
I
that
think-
would make it easier or not.
No, I think longitudinal studies have like a whole other issues that you have to deal with, of like participants dropping out, missing appointments and all that.
Gotcha. No, that makes a lot of sense.
Yeah, so I think we stick with this outline, but we keep in mind the informed consent, which we will have a whole section on.
I'm just gonna bold that. That's a really good point, guys.
and we have to keep this in mind when we're analyzing or looking at the results, because we could see confounding factors being that, say one patient comes in multiple times in the hospital for one problem, they'll be counted multiple times.
Is there a way that we could make it so they just are counted once? Like we have a database and it accounts for that patient, so we're not counting them more than once?
That's only if the hospital has them coded a certain way when they come, when they go visit the cath lab, that they're the same patient. Otherwise, yeah, I don't know how that data looks like.
Well, could we just make that inference if we're making the data up?
We're not making the data up. We won't actually analyze any data.
Yeah.
Yeah.
So maybe that's just something to discuss. Definitely like in the data analysis, how we're going to account for, a patient that comes in, 10 times, and every time they're found to have, massive coronary artery blockages. So it would probably be inappropriate to count, 10 cases of heart disease in that one patient. So that's a really good consideration.
Especially because those patients would be coming in more often than patients without coronary heart diseases. Most likely.
Yeah,
Mhm.
I agree. Okay, those are really good points. Definitely apply to the later sections of this project.
Yeah, for our sample and data discussions, we'll have to figure that out.
Yeah. Does anyone else have anything to add for that? Point 4. Okay, we'll go on to point 5. So we kind of started talking about this already. But what did the researchers do to control confounding participant characteristics? Were the procedures effective? Discussing threats to the study's internal validity. And did the design enable the researcher to draw casual inferences about the relationship between the independent variable and the outcome? So kind of what we have here, there are several confounding participant characteristics to wrestle with. Socioeconomic background is a major component, includes issues such as poor nutrition, lack of education, exposure to environmental hazards, complete lack of access to healthcare altogether. Threats to internal validity include misdiagnosis, underdiagnosis, or a diagnosis that exists outside of the cath lab. That's definitely something I want to talk about more. They would be omitted from the study. Issues of racial bias are alive and well in healthcare. Additionally, the one thing that I was thinking about is if you identify as African American, that can be subjective, especially people in this country are blended with a lot of racial backgrounds. So that's something to wrestle with. This is kind of a smaller threat to internal validity, but it's something to consider. Just the last year of our study, COVID was going on. So some people, they might have delayed their procedures to go to the hospital for fear of getting COVID, but other people, COVID might have exacerbated their sickle cell or their heart disease. So that's kind of something that is definitely a consideration to think about when looking at the data. But that being said, as long as we take these factors into account and discuss them and make sure that they're put into context, I still think that we'll be able to, analyze that relationship between the independent variable, the sickle cell disease, and the cardiac disease. So, anyone have anything to add for this piece?
I think that's covered pretty well.
Yeah, I think that's very thorough. Good job.
Yeah. I think the COVID part too was actually really important. That's something I didn't even think of. So
I think that's also a good reason why we do a retrospective study, because starting today or like starting in 2020, there'd still be issues with COVID.
Yeah, probably massive issues. I know a lot of people's elective, procedures are still getting canceled and delayed, and it's, going over 2 years on this pandemic. So
yeah, by choosing 2010 to 2020, we minimize the effects of COVID on our study.
mhm.
Okay, so we'll move on to point 6 here. So we already talked about the pandemic could potentially impact, maybe it wouldn't, maybe it would look similar because they would kind of offset, but it could be a consideration for that last year. We talked about people were getting their procedures delayed, or people that were having exacerbations to their health because they had COVID. Another thing to discuss is the study was limited to the Boston area, which obviously I think, Boston is a diverse area, but we're not going to perfectly be able to represent the population of the country or for the entire world for that matter. It's, completely impossible to sample the entire country or the entire world. So this just gives us a microcosm that we can feasibly look at, and it's, it's in proximity to all the researchers, which is us. And we're familiar with these hospitals. Northeastern's familiar with these hospitals. So we're not just, going somewhere, randomly and, trying to study and conduct our research. There's already a relationship built up there. Additionally, there are individuals in the population of interest who likely do not have routine medical appointments, or they never underwent cardiac catheterization. So cardiac catheterization, though it is a very good procedure for diagnosing cardiac disease, not every patient with cardiac disease is going to go to the cath lab. They can get diagnosed via an echo, or maybe they're admitted very late in the process and they don't even really do a lot of the diagnostic procedures they would usually do, or they never go to the hospital altogether. So those are all kind of limitations that we're running into. Does anyone have anything to add for that part?
I mean, you briefly touched on it, but our study is going to be limited to people who have access to healthcare and the ability to receive follow-up appointments.
Yeah.
And maybe someone was recommended they get cardiac catheterization, but they don't have insurance or they can't afford it.
Yeah. So insurance, that's a good point. I totally didn't mention that at all.
Yeah. So would probably rule out certain socioeconomic classes,
Mhm.
and maybe immigrants and stuff.
Does anyone have anything else for our limitations?
We can add in what we mentioned before about if patients come in multiple times, we're not able to keep track of them.
Yeah, that's an issue we have now, but maybe when we do our sample discussion or data discussion that we're going to would fall under, we can look into ways to avoid that.
Does anyone have anything else for this portion?
No.
Okay. So with that being said, we'll move into our sampling plan. So the first question here was the population identified? Were eligibility criteria specified? So the population of interest is African American males and females over the age of 18 who visited a cardiac catheterization lab. They're resulting in the diagnosis of heart disease in one of the 3 sites selected for the study. I already kind of talked about this, but African American is defined as anyone who identifies as African American on their medical record. Did I miss anything with the population or the eligibility criteria?
Nope. It's all good.
No, I think that's good.
Okay. And I didn't list the 3 hospitals out again here. We already discussed those and we're familiar with them. Okay, so what type of sampling design was used? Was sampling plan 1 that could be expected to yield the representative sample? So the research proposal utilizes consecutive sampling and recruits all participants from our accessible population of interest during the defined time period. So the proposed sample, we're going to look at every patient that went to the cath lab during those 10 periods. We're not grouping them. We're not doing the random sample. We're doing consecutive sampling. So after all the records are gathered, purposeful sampling will then be used. So first we use the consecutive sampling to get those patients from those 3 hospitals in that decade. And then we go into purposeful sampling. So we're going to filter out patients that don't meet the race criteria, patients that don't meet the age criteria, patients that don't meet the diagnostic criteria, and that will comprise our data set. I also added that there's an elements of convenience sampling here because the three hospitals, if you were doing a random sample, you would have all the hospitals and you would have a way to randomly select which hospitals you were going to look at to do the study, which would probably yield a more representative result. But these are three hospitals that are close to all the researchers. And it's feasible to do. So that's why there's also an element of convenience sampling here.
Mhm.
I think there's an element of convenience sampling in most research. So I don't know. It is what it is. Does anyone have anything to add for this?
I just had a question. So I know we talked about it before, but should we specify that it's excluding sickle cell trait only, or?
I think that's a really good point. Yeah. Because there is a lot of,
There is overlap.
there is overlap.
Yeah. And most studies that we found in our research pointed to sickle cell trait
Mhm.
not having a correlation with sickle cell disease.
Yeah.
So just like explicitly stating that, I think that's important. Definitely missed that. Is there anything else in the sampling plan?
I think that's good.
Okay, and then the third point here were characteristics of the sample described. So the sample, we look at percentage female, percentage male, mean age of both males and females, number of participants sickle cell disease positive, number of participants sickle cell disease negative, and then the number of patients with heart disease. Are there any more variables that we want to look at or that we missed? I'm just going to emphasize again that we're not looking at sickle cell trait here.
Yeah, I think that's good.
Yeah, that seems good.
Okay, so that wraps up our sampling plan and kind of our rehash of our methods portion.
Yeah, now that we've clarified that.
Yeah, now that we've got that all straight.
Thank you for looking into that.
Yeah,
thank
no
you.
problem. So with that, I'll go ahead and stop the recording.